In what's been dubbed by Time magazine as the Angelina Effect, actress Angelina Jolie's recent public announcement about her decision to undergo a preventive double mastectomy because of a faulty gene has focused a spotlight on genetic testing and prophylactic mastectomy. I'm Jane O'Brien, and I've put together this video in an attempt to address some of the questions that I, as a specialist breast surgeon, have repeatedly been asked following Angelina's recent announcement, such as, could I have the breast cancer gene? Should I be having genetic testing? And even, can I have an Angelina? I think the first thing to emphasise is that whilst breast cancer is unfortunately a common disease, only 5 to 10% of all breast cancers are related to an inherited genetic abnormality, and less than 1% of the population have a mutation in one of the major breast cancer predisposition genes, BRCA1 and BRCA2. Whilst the average lifetime risk of breast cancer to age 85 for Australian women is around 10 to 12%, for the very small proportion of the population who do have a genetic mutation, the lifetime risk may be up to 80% or more, as well as a 40 to 50% lifetime risk of ovarian cancer. These women can face potentially life-challenging decisions whilst often at still a very young age. The BRCA1 and BRCA2 genes are tumour suppressor genes, which were identified in the 1990s. A normal cell has 2 functional copies of each gene. Individuals with a BRCA mutation have inherited 1 non-functional copy of the gene in every cell of their body. These individuals therefore require only 1 further hit or mutation to knock out the remaining functional copy of the gene, making cancer development much easier, and hence the development of cancer at a younger age. Both of the BRCA genes are inherited in what we call an autosomal dominant pattern, meaning that only 1 abnormal copy of the gene is needed to increase an individual's predisposition to breast and/or ovarian cancer, and there's a 50-50 risk for an affected parent of either sex to pass on the mutation to their children of either sex. The family history is therefore equally important on both sides of the family, not just the mother's, as is a common misconception. Mutations in the BRCA genes cause particular patterns of cancer down the generations. The estimated frequency of BRCA mutation carriers in the general population is around 1 in 1,000 people. The frequency in certain specific population groups can be higher. For example, in people of Ashkenazi Jewish descent, the rate of mutation carriers is 1 in 50 to 100 people. Features suggestive of a potential BRCA or BRCA mutation within a family are multiple cases of breast cancer on the same side of the family, often with early onset, such as age less than 40 years, ovarian cancer in a family with a history of breast or ovarian cancer, breast and ovarian cancer in the same woman, cancer in both breasts, certain ancestry, such as Ashkenazi Jewish, and male breast cancer. Women who are concerned about their family history and the potential risk of a BRCA gene can obtain more information on the Cancer Australia and Breast Care Network of Australia websites, and should discuss their family history with their general practitioner in the first instance, who will, if appropriate, arrange for onward referral to either a breast specialist or directly to a familial cancer centre, where a more formal genetic risk assessment can be performed. Another group of women in whom Angelina's announcement has raised questions are women with a recent diagnosis of breast cancer themselves. Certain breast cancer pathological subtypes are more common in association with BRCA mutations, and if, for example, a triple-negative breast cancer is diagnosed in a very young woman, genetics assessment may be indicated even in the absence of a family history. The identification of a BRCA mutation in a woman with recently diagnosed breast cancer can be very clinically relevant and significant, as it may have a significant influence on surgical decision-making, perhaps prompting the patient to make the decision to undergo bilateral mastectomy with or without reconstruction, rather than breast-conserving surgery or lumpectomy followed by radiotherapy. Genetic testing, which involves a blood test, is provided to consumers through familial cancer centres, which are generally co-located within public hospitals. Genetic counselling is a vital part of this process. Publicly funded testing is usually offered when there's felt to be a 10% or greater chance of a mutation being present. Consumers may also elect to pay for testing through private laboratories. However, it is strongly recommended that this be performed under the auspices of a genetic service to allow appropriate interpretation and explanation of the results by trained genetic counsellors. Genetic testing can open a floodgate of mixed emotions within a family. The range of psychological issues associated with genetic testing highlights the importance of both pre- and post-genetic counselling as a key component of the process. For women in whom a BRCA mutation is identified, various risk management strategies are available. The precise breast cancer risk for an individual woman will vary according to several things, such as her age, the number and age at diagnosis of affected family members, and the exact nature of the fault in the gene. The main options to manage breast cancer risk are surveillance, risk-reducing medical therapy, or prophylactic double mastectomy, the most effective form of prevention. There are many factors that may affect a woman's choice. For example, how old she is, whether she's had or planning to have children. As there's no effective form of screening for ovarian cancer, there's a recommendation for BRCA carriers to have the ovaries and tubes removed at around age 40 or after childbearing is complete in order to reduce the risk of ovarian cancer. And if this is performed prior to the menopause, it in addition also reduces the risk of developing breast cancer by up to 50%. Intensive breast surveillance is recommended, which involves regular clinical breast checks and yearly screening with mammography, perhaps ultrasound in addition, and more recently also MRI scanning. Research has shown that MRI can pick up cancers early, even in young women in whom breast density limits the sensitivity of mammography. This has not, however, yet been shown to improve survival, and MRI also unfortunately has a high false positive rate, meaning it picks up many non-cancerous changes. In 2009, the Australian government introduced a Medicare rebate for MRI screening for women who are at high risk of developing breast cancer. This is currently the only situation in which breast MRI is subsidised, and eligibility criteria are fairly strict. Women must be under the age of 50, fall into a high risk category as determined by specified family history criteria, and the test must be ordered by a breast specialist. All these surveillance screening strategies, it must be emphasised, are based on early detection, not prevention. Screening does not alter the risk of developing cancer. The goal of screening is to find the cancer early when it may be potentially most treatable. BRCA1 carriers in particular, however, often develop so-called triple-negative breast cancers, which frequently require chemotherapy even if found at an early stage prior to spread to the glands under the arm. In addition, in contrast to non-genetic breast cancers, where early detection with screening increases the chances of less radical surgery in the form of lumpectomy, in gene carriers who develop breast cancer, breast-conserving surgery may not in fact always be the most appropriate surgical option for them because of the risk of subsequent development of a second breast cancer in the same breast or one in the opposite breast. The risk of breast cancer in the opposite breast in a BRCA1 carrier is up to 40% at 15 years, and as such, women may be medically better served by bilateral mastectomy with or without reconstruction, meaning that early detection in this situation may not in fact result in less radical surgical treatment. There are several options that can be considered to actually lower the risk of developing breast cancer in women with BRCA mutations. As in the general population, it is advised that gene carriers adopt lifestyle practices known to reduce or modify breast cancer risk, such as regular exercise, limiting alcohol intake, and weight control. Taking risk-reducing medications is also an option to lower the risk of developing breast cancer for women identified to be at increased risk. The most commonly used risk-reduction medications are tamoxifen and raloxifene, taken daily as a tablet for 5 years. These medications have been shown to reduce risk by up to 40 to 50%, but despite this significant risk reduction, uptake of this option is for a number of reasons very low. Finally, there is the most radical but most effective option, and as a surgeon, my particular area of interest and expertise, the preventive or prophylactic double mastectomy. This surgery involves removing as much of the at-risk breast tissue as possible. It's not surgically possible to remove every last breast tissue cell while still retaining an adequate blood supply to the envelope of the skin of the breast, and the risk is never therefore going to be reduced to zero. Surgery to remove the breasts does, however, dramatically reduce the risk of breast cancer, and I would agree with the figures which have been in the media recently, widely quoting a 90 to 95% risk reduction. As Angelina herself outlines in her New York Times op-ed, based on an estimated reduction of over 90% for prophylactic mastectomy, the lifetime risk of breast cancer in a BRCA mutation carrier after the risk-reducing procedure is under 5%, which is less than half that of a non-carrier with two breasts intact. Women have very different attitudes about their breasts, and discussion about preventive mastectomy can evoke a wide range of emotions. There are many women who have an increased risk of developing breast cancer who feel that preventive mastectomy is a very extreme procedure and know it wouldn't be for them. Some women know immediately that preventive mastectomy is best for them, and others spend a great deal of time considering it before coming to a decision. A woman's decision about preventive mastectomy will be influenced by a number of things, which may include her experience of cancer within her family. If you are considering a preventive mastectomy, it's important to spend as much time as you need and to have access to information so that you know that you've made the right decision for you. Get as healthy as possible before the surgery, and if appropriate, lose weight. This is elective, non-urgent surgery. The timing of surgery is obviously an individual decision, but should take into account things like whether you've already had children or are planning a family and would like to breastfeed, the impact that developing breast cancer would have on your family responsibilities and lifestyle, and your current age. For women identified as having a faulty breast gene, the estimated risk varies with age. For women in their 20s, for example, the risk of developing breast cancer over the next 10 years is very small. But by age 40, the risk of developing breast cancer over the next 10 years has risen to 10 to 20%. Consultation with a clinical psychologist who's knowledgeable and familiar with the impact of risk-reducing surgery is often useful. The decision to undergo risk-reducing surgery can be a complex one, and even after a decision has been made, the process, including the surgery and beyond, can be physically and emotionally very challenging. It should be emphasised that consultation with a psychologist is not an assessment of suitability for surgery or about your competence in making decisions. It is an opportunity for you to discuss your decision and to consider the emotional, physical, social, sexual and interpersonal implications of the surgery. It can be also useful to meet with someone who has undergone the procedure themselves, especially if they've been under the care of your own breast surgeon. Most health professionals in this area are sensitive to the complex issues involved when considering preventive surgery. Given, however, that preventive mastectomy is relatively uncommon in Australia, with less than 20% of proven BRCA carriers undergoing prophylactic mastectomy, some health professionals you come across may seem a little uncomfortable about your choice. They may not appreciate the difficulties experienced when faced with the decision. If you find that you're not able to relate to a particular health professional, don't be afraid to seek out a second opinion. The breast surgeon is the first point of contact in this process and in effect acts as the gatekeeper to the rest of the surgical team, including the plastic surgeon, so do your research and preferably aim to see someone who has a special interest in this area. Also, don't be afraid to shop around. If the breast surgeon you've been seeing does not offer the procedure you wish to consider, such as nipple-sparing mastectomy for example, go elsewhere. This is an important and most importantly irreversible decision. Don't proceed with the surgery just because you've been seeing a surgeon for many years for screening if you're not comfortable with the choices being offered. And finally, the area which for me has generated the largest number of questions and provoked the greatest degree of interest, the technical surgical details of Angelina's procedures. These are in the public domain, outlined in some detail on her breast surgeon's blogspot. Unsurprisingly, Angelina elected to undergo immediate reconstruction, which is the preference of the majority of women undergoing preventive mastectomy. The type of reconstruction was implant-based, again the most common choice in preventive double mastectomies, as these are usually performed in younger women who characteristically may not have enough native tissue for flat-based reconstructions. Angelina also elected to preserve the nipples. Despite a growing body of evidence showing that with proper patient selection and operative technique, nipple sparing is a safe and effective intervention, especially for patients undergoing prophylactic mastectomy, and also its potential for improved cosmetic and psychological benefits, this type of surgery is not yet widely available in Australia. This is largely because of dual concerns regarding oncological safety and the surgical risk of the more ambitious and complex surgical technique. In the United States, reports from multiple centres have confirmed that both prophylactic and therapeutic nipple-sparing mastectomy can be consistently performed with low recurrence and low complication rate, and nipple-sparing mastectomy is slowly entering the mainstream for both the treatment and prevention of breast cancer. There are a variety of incisions that may be used, and Angelina chose an inframammary incision beneath the breast. Surgical complications related to nipple-sparing surgery are not unusual. The ability to oxygenate the breast skin is related to the blood supply, and the blood supply to the nipple and areola may be particularly tenuous following nipple-sparing mastectomy. It was for this reason, in Angelina's case, that the uncommon step was taken to perform a nipple delay procedure. 2 weeks before her mastectomy, a nipple delay was performed, which involves dividing the blood vessels and the other breast tissue beneath the nipple so that it was no longer dependent on the underlying tissue for blood supply. The nipples become accustomed to getting their blood supply from the skin around instead of the breast tissue underneath that will be later removed, which can potentially help them survive the surgery. Nipple delays are very uncommonly performed in most breast surgeons' practices, usually being reserved for patients who've had previous breast surgery, especially if the nipple's been previously moved, as there may be incisions that disrupt the blood supply and the blood supply is then less dependable. 2 weeks later, Angelina underwent bilateral nipple-sparing mastectomy with insertion of tissue expanders and allograft. Allograft refers to an acellular dermal matrix, which is a surgical mesh derived from human skin that's been treated, processed and preserved so that it can safely be left in the body, and it provides a hammock that cradles the tissue expander or implant, providing cover and helping to create a more natural shape and contour. This operation was described as taking up to 8 hours, which in my personal experience is far longer than would be standard. Given the current interest in the States in one-stage direct-to-implant reconstruction in conjunction with the use of these acellular dermal matrices, I was interested to note that the traditional, more cautious two-stage approach was adopted in Angelina's case to reduce tension and pressure on the mastectomy skin flaps and maximise the chance of preserving tissue viability. The rest of the process was fairly standard, with gradual inflation of the tissue expanders followed by their exchange for permanent implants 10 weeks after the initial mastectomies. In her New York Times piece, Jolie wrote, "I wanted to write this to tell other women that the decision to have a mastectomy was not easy, but it is one that I'm very happy that I made. My chances of developing breast cancer have dropped from 87% to under 5%. I can tell my children that they don't need to fear that they will lose me to cancer. I chose not to keep my story private because there are many women who do not know that they might be living under the shadow of cancer. It is my hope that they too will be able to get gene tested, and that if they have a high risk, they too will know they have strong options. Life comes with many challenges. The ones that should not scare us are the ones we can take on and take control of." Thank you.